vitamin B12 or folic acid. And the second pillar tackles the blood loss.
Yeah.
So this should be reduced. Therefore, in order to do so, surgeons need to use a meticulous surgical technique. Then, whenever possible, cell salvage should be used. This is a technique that kind of collects the blood that is bleeding during the operation, washes the blood and gives it back to the patient, so the patient gets back his own red blood cells and not those of a blood transfusion. And there are other means during the operation, like local hemostasis with local hemostatics, with maintaining normothermia and maintaining a good coagulation during the operation that limits the blood loss. And last but not least, the third pillar is that, you know, a low hemoglobin, whenever this occurs, despite all the measures described so far, then this does not and should not result in an immediate non-reflected transfusion, because there are other means to improve oxygen delivery to the tissue, like giving additional oxygen in the ventilation of surgical patients.
So can you tell me about why is this, for example, better than giving patients blood products, if the technique that you're using?
Yes, there are hundreds of studies in a total of several million patients that clearly show that transfused patients do have a higher mortality than non-transfused patients. Transfused patients stay in the hospital longer than non-transfused patients. Transfused patients have organ dysfunctions due to the transfusion, particularly lung dysfunction, renal insufficiency, stroke, and myocardial infarction. And also, transfused patients do have more frequently infections. I'm not talking about the transmission of HIV or hepatitis via blood transfusion. These are regular bacterial infections, but they are very significant, very relevant for the patient. And last but not least, transfused patients do cost a lot more than non-transfused patients.
Yeah. And Professor Axel, can you tell us about if this technique can improve, for example, the mortality rate of the patients?
Yeah, we have two ways to look at it. The one way is what are telling the studies on transfusion and the dose-dependent change of outcome. That has been described by my colleague. The other question is now, if I do manage the patient's own blood rather than resorting to a transfusion or donor blood, do I actually improve the outcome? And there is a number of studies, and I would say almost every other month there is emerging additional evidence that shows that yes, applying the principles of patient blood management is significantly reducing mortality, in-hospital mortality, 30-day, 90-day mortality, and composite morbidity. And what is very important, it clearly reduces average or mean length hospital of stay. And if we look at the financial ramifications of patient blood management, we did an assessment for the probably 15 to 16 million blood components transfused annually in the United States. And with all these transfusion-related services, the product costs themselves, plus the added complications, we might look at a burden to the health system at the vicinity of $100 billion annually, just for the United States.
Yeah.
And it's quite interesting that the World Health Organization in 2010 has endorsed the principle of patient blood management as a necessity for modern health systems. And so we are very pleased that the government in Kuwait, or especially the Department of Health, has signaled an interest in in the implementation of this good medical practice in your system. And I just came from Australia, which is one of the hubs. I'm working for the last few years, and Professor Spahn is also a member of the International Faculty for Patient Blood Management in Western Australia. This is the first country in the world that has implemented patient blood management, or PBM as we call it, on a statewide basis. This is now the end of a 5 years pilot program for Australia, and we managed to reduce the transfusion rates per 1,000 population, that is the international measure to look at blood utilization, to a level which is about 50 to 70% below European and American numbers. At the same time, we have shown that we clearly reduce the length of stay, the number of nosocomial infections, etc. And this, of course, is now a signal for the entire Commonwealth of Australia that they want to implement this.
So it is actually, as well, it's money-saving technology as well. Now, the thing about this, can you just, back to my question is, talk to us about the technology itself, like how does it work? And if it's, do you have any demonstrations for us about it?
Yes, we have a demonstration of what happens if stored RBCs are being transfused, and this is one of the mechanisms how these adverse outcomes can be explained. You know, observing an adverse outcome, that's very important, but if you can explain how it happens, what are the mechanisms, then if you have such mechanisms, then it makes it much more believable that there is a cause and effect relationship. And the reasons behind these adverse outcomes, these complications, are in several categories. First, a blood transfusion is actually an organ transplantation, if we want to be clear, which induces an immunosuppression of the patient, so he is more prone to develop an infection, for example. Or if an infection starts, the transfusion of blood products accelerates this infection. And the second category of mechanisms is due to the fact that RBCs, when they are stored in the blood bank, even at perfect storage condition, they become, each day they are there, they're becoming stiffer and stiffer. And RBCs, and that's what we will see in the video in a minute, are becoming so stiff they cannot even penetrate correctly the tissue. And so,
which is a major problem. Like,
this is a problem, because we are giving, or traditionally RBCs are being transfused to improve oxygen delivery to the tissue, but the vehicle, the RBCs that should bring the oxygen to the tissue, cannot penetrate it anymore. So we will see that. And the other aspect of this stiffening of the RBCs is that they become more and more prone to hemolyze, fall apart once transfused to the patient. And this falling apart of the RBCs results in a liberation of the hemoglobin out of the RBCs into the circulation, and this results in vessel damage, in kidney damage, in vasoconstriction, lung damage, and many other adverse consequences. And all these mechanisms together really nicely explain how the patient comes to the observed complications.
So, can we see the demonstration?
We should have a look at this. This is footage from the Department of Bioengineering at the University campus of San Diego, California. And what we see here is a hamster window model. We see the normal microcirculation before a blood transfusion into a hamster. And What you see here is a very nice and equal distribution of red cells in single cell capillaries, also in multi-cell capillaries. So this is the normal, the perfect condition. Now, we also have the same animal model with the transfusion of stored blood after the hamster has been hemodiluted to about 20% and then transfused with stored blood. And you see that there are some sections where there's an absolutely still stand. There's basically a breakdown of the architecture. The microcirculation, in fact, does not work at all, and therefore the gas exchange is impeded.
Yeah.
And we have the same also in humans. Here is a patient who lost a tremendous amount of blood due to a ulcer bleed, and he is down to 2.8 grams of hemoglobin, which means he has lost about 80% of his red cells. But he is resuscitated, and you can see there is a relatively good distribution of the remaining red cells. Now, the same patient, after he gets a 3-unit transfusion, shows exactly the same picture as we have seen before in the animal model. Again, there's sludging, there is a change in the entire dynamics. Of course, this doesn't advocate that we want patients to bleed that low, but it shows that the transfusion, in fact, does not do what people expect it to do.
And can you tell us, like, what other problems would this solve? Like, are there other problems that this technology can solve?
Yes,
and can help us with?
Many countries, and I think I heard today in our visit at the local blood bank here in Kuwait City, that you have quite often shortages of blood products.
And also an access as well.
Yes. And the problem of product shortage becomes a chronic problem in those countries where we have aged populations, like in many European countries and Asian countries. And because this product cannot be stepped up in production like a pharmaceutical product could, so we need to find ways how we can ease the stress on the donor population, and patient blood management is definitely one of the ways to do this. And just to give you another example, one of the big users of allogenic blood components is orthopedic surgery and cardiac surgery. In the programs we work together, like in Australia and also several centers in the United States, our team has managed to decrease the transfusion rates in orthopedic surgery to literally 0 over more than 1,000, 1,500 consecutive hip and knee replacements. So that shows it is doable, it's feasible, and we see again very, very short lengths of stay with those patients.
And the outcome improves
very much so.
dramatically.
In parallel with the decrease in the transfusion rate, the outcome improves.
Yeah, absolutely. Now, the thing is, with this eliminate the use of blood products in the future, or do you think it's not possible?
No, it will not eliminate the need for blood products in the future, not at all, because there are always, emergencies, big trauma, car accidents, big burns or whatever, where you cannot plan everything. So these specific groups of patients will always need some blood products. But what we aim at is to better direct the blood products to those who really need it and avoid all the unnecessary transfusion. That's our aim, to avoid all unnecessary transfusions. But in emergency situations, some aspects of patient blood management are also important. For example, cell salvage can also be used in emergencies.
Which is amazing.
Looking at blood coagulation and avoiding hypothermia are also very successful important principles in, for example, trauma treatment.
Yeah.
We were trying to quantify the potential savings in a macroeconomic, health macroeconomic simulation. And it's interesting, if you look at the distribution of all transfusions given, the majority, in fact, is given to hemodynamically stable patients. This means transfusions of 2 to 3 units during the entire hospital stay. And we did in Austria, not in Australia, this time in Austria, we did a large prospective observational study on transfusion behavior, and we saw that for matched patients, transfusion variability between centers varies in a range of 1 to 17. So hip replacement in hospital A is almost certain, while in hospital B it's very rare for the same patient. So variability is a problem of a major economic magnitude. And then we saw that about 97% of all transfusions are predictable by the 3 factors, by the 3 risk factors my colleague Professor Spahn mentioned in the beginning, which is undetected and uncontrolled anemia, poorly controlled blood loss, and a very liberal transfusion trigger. Now when you can predict 97% of transfusions in hemodynamically stable patients, then you see the potential of tackling these 3 factors by the 3 pillars of PBM, and the savings are enormous.
Now, during your visit in Kuwait, is there any, for example, collaboration or studies you're going to do here?
I mean, the final aim is to implement patient blood management in Kuwait, and the first step into this direction is that we are planning a study in a Kuwait hospital, most likely in orthopedic surgery, where the Kuwaiti doctors can show that following the patient blood management principles reduce transfusion needs also here, and they can observe and experience personally, and their colleagues also, how better their patients do, and we will gather all this information to make a proof of principle that is the same here as elsewhere, to motivate also physicians to participate at the second stage.
That's perfect. Thank you so much, first of all, for being in the show, and also for bringing this technology and project in Kuwait, and thank you so much for being here.
Thank you,
Thank you very much for the honor of being here.
Thank you.
Thank you. And now we will go for a short break, and we will be right back with another guest and another topic as well. So just stay tuned.
I'm a registered dietitian from Dasman Diabetes Institute, and today I'm going to be talking about healthy eating before and after exercise. So just like a car needs fuel, our body needs proper nutrition to perform activities of daily living, such as moving, walking, thinking, studying. All of these activities need energy. And so an activity like exercise needs even more energy, and for a person to have all that energy, he must nourish himself with proper foods. If we consume foods that are unhealthy, such as fast foods or chips or chocolates, we will get energy, but we won't be able to perform at our full functional capacity. And so by eating healthy foods, we can perform to our full functional capacity. So there are foods that we should consume before exercise and foods that we should consume after exercise. As for timing, some people like to be light when they work out, so it's better to eat at least half an hour before a workout. Sometimes people feel more comfortable with an hour, but half an hour to an hour is the best time to eat. What are the foods that you should eat? The foods that you should eat should consist of carbohydrates because they're the most readily available source of energy. So foods that have carbohydrates include sugary foods such as fruits, dried fruits like apricots or raisins or dates, which are famous in Kuwait, bananas. The foods also shouldn't have a lot of fiber because fiber takes a long time to digest and you need the sugar right away because you are going to exercise. The food should also be low in fat, so you don't want to eat like a burger or something like that before working out because you'll feel heavy. And most of the blood will go to the intestines to digest the food and not to your like legs or hands which will be performing most of the activities. Another food that's delicious and pretty light is like yogurt with dried fruits or yogurt with fresh berries. It's also healthy and nutritious right before exercise. Now the other thing is some people exercise and they feel like, okay, now that I've exercised, I don't want to eat anything because I just did all this work, I burned all these calories, and I don't want to like ruin everything I did. But it's not healthy. You need to eat after exercise because just like when a car moves, it burns some of the fuel, so you need to replenish the fuel. You need to do the same for your body. So what are the foods that you should eat after exercise, and when should you eat these foods? First of all, you should eat within 2 hours after exercise because there's an enzyme in the body and it functions most 2 hours after exercise. So don't wait, like for example, let's say you exercise at 5. You don't want to start eating at 8. You want to eat within 2 hours. So by 7, you should have eaten like a snack or a meal. After exercise, you need to consume a meal or a snack that contains both protein, which replenishes all the lost muscle and repairs all the muscle damage, and you need carbohydrates because you've used most of your sugar stores. So proper foods would be, for example, a sandwich, like a turkey sandwich, which has lean protein. It's a good source of protein. And just whole wheat bread, which provides you with the carbohydrates, it also provides you with fiber. And just add in a bit of vegetables like lettuce and tomatoes because they give you vitamins and minerals. And you also need that for exercise. Another proper snack, if you don't feel like making a sandwich, something fast and easy, is milk and like a banana or another type of fruit of choice. Now why is milk really important after exercise? Because it contains 2 types of protein. It contains casein and whey, and they act differently. Like one is fast acting, or like it's digested more quickly than the other, so it slowly replenishes all the lost muscle and repairs all the muscle damage. So milk is a really good source of protein. Also has calcium for strong bones and teeth. And the banana, which has carbohydrates and vitamins and minerals. Another snack, which is easy, and you can find it and like just buy it from the supermarket, just cereal with milk. As we said, milk is very important, and you can add in like a bit of fruits like berries or bananas for some people. So these are just a bunch of healthy snacks before and after exercise. So make sure you eat before and after for a healthy workout and a workout that you can get the most benefit from.
Made up of hollow bones called vertebrae. Between vertebrae are the vertebral discs that are made of tough elastic material and act as shock absorbers. These discs can degenerate and become weak with age or due to an injury. Disc prolapse happens when the soft inner material of the vertebral disc bulges or bursts through the outer lining of cartilage and puts pressure on the spinal nerve. This irritation causes constant back pain. Prolapse discs are common in people who are involved in tasks that require a lot of twisting and turning of the back and spine. Muscle spasms also occur when the spinal nerves are irritated or damaged. Disc prolapse, medication and treatment. Extended bed rest. Analgesics. Anti-inflammatory drugs. Muscle relaxants. And surgery. In severe cases, a surgery called laminectomy may be required. The laminectomy surgery is designed to remove a small portion of the bone over the nerve root and or disc material from under the nerve root to give the nerve root more space and a better healing environment. This allows the spinal cord to float backwards and gives it more room, reducing the pain.
Welcome back to our show. We have our other guest, who is Professor Adel Al-Awadi, and he's a consultant of rheumatology and head of the rheumatology unit in Amiri Hospital. Thank you so much for being here, first of all.
Thank you, Noor, for your invitation, and I really congratulate you for this valuable and helpful program. I'm sure it's useful for everybody because it deals with the health, right?
Absolutely.
And everybody likes to live a healthy life and without suffer or pain. So
yeah, should watch also Healthy Life. Now, today we're going to talk about, you know, rheumatological diseases in general. Like, what does a rheumatological disease mean?
You know, most of the people, they think rheumatology is one disease.
Yeah.
They say rheumatism. This is wrong. You know, rheumatology, even most of the people, and even the medical students, even the doctors, they don't know what does it mean, rheumatology.
Yeah.
And when I come to the teaching, you know, the first thing I ask them, what's rheumatology? And all of them, they tell me a wrong, what's called wrong, not diagnosis, the wrong terminology.
Yeah.
Rheumatology means, rheuma is coming from the Greek, means flow or movement. Ology means science. So it's a science of movement. Human being is always in a constant movement. 24-hourly he moves. Even during the sleep he moves.
Yeah.
We are sitting and moving. You're moving your body, your joints, okay? So anything happens to you which affect your movement is under rheumatology.
Yeah.
And there are main organs that keep you moving. Everybody knows you should have a good joint, good muscle, good bone, and these bones are connected by ligaments and tendon, and also they are supplied by arteries, veins, and nerves. So whatever happened to these, at the end, it affects your movement.
Absolutely.
If you have inflammation with the joint, you cannot move your joint. If you have some problem with the bone, you cannot move your body. Or the muscle cause weakness.
It's a harmonious system.
It's a harmonious system.
Yeah.
So whatever happened to this organ, it is under our subspecialty.
Now, the thing is, we are, you know, seeing a lot of increase in rheumatological diseases, but can you just tell us some of the rheumatological diseases that are very common in Kuwait?
Yeah, no, we classify rheumatological disease under 10 classifications.
Yeah.
And under each classification there is more than 20, 30 diseases. And one of them that we see, we did a study in Kuwait in year 2000, 2003, and we found number one common disease is called soft tissue rheumatism.
Yeah.
What does it mean? It means pain and inflammation, structure around the joint. For example, the common site we have is the knee pain. Knee pain. It's not from the joint itself. It's the ligament or tendon around the knee. I'm sure everybody will ask me, what are the tendon and ligament? Just I want to show this picture, you know.
Yeah,
Just show
go
me.
ahead. It will be
Yeah.
nice.
This is a joint. If you put the focus on the picture, this is a knee joint.
I think there is just a tiny bit of a technical difficulty.
Okay.
Yeah.
So there is that knee joint composed of two bones and a patella,
Yeah.
and there are muscle around it, and there are tendon and ligament. These ligaments very important because it keeps the joint moves in one block. Because there are two bones, so you don't want one bone goes first and then the other bone comes. So otherwise our work will be affected and everybody will fall. So whatever happens to these ligaments, everybody will lose this balance and they fall.
Yeah.
So it goes giving way the knee. So the common disease came in the Kuwait, number one, we call soft tissue rheumatism. So knee pain, the commonest is tendinitis. Number two, it came the back pain due to the muscle problem. It's not muscle problems, also very common cause back pain. And most of them came from, number one, because they sit for a long time in the chair and they don't care about for how long they sit. And they're sitting in the chair, their back is forwarded, and they play with the computer hours. At the end, they complain of the back pain.
Exactly. I think it's a major problem that we're seeing very often now is back pain. And it's usually, as you said, from sitting long hours.
Long hours. Number two is because sun exposure to, if you get in the hot weather to cold, like air condition, and get sudden exposure to your back to the cold, it comes severe muscle spasm and pain. Or you are lifting heavy things, you know. There are now colleges in the United States, they teach you how to carry things, how to sit, how to sleep, how to work. These all prevent you from a rheumatic problem. So soft tissue rheumatism, which is pain in the muscles or in the tendon, is number one came. Number three is came the shoulder pain. Shoulder pain is very common.
It's extremely common.
Very common. Shoulder pains, you know, if you play in the computer a long time, cause shoulder pain. If you carry heavy things, cause shoulder pain. Those who play sports, they go and they try to, you know, lift heavy things. At the end,
and now it's almost like a fashion now.
Fashion now, they want to build muscles. And at the end, if you carry heavy things and you don't look after how much you have to lift, at the end,
and the technique is wrong.
Technique is wrong. There's a term in the rheumatology called repetitive strain or sprain syndrome. Anything you put strain on it every day and don't put it in the right way, at the end cause problem, pain or inflammation in the joint.
Now, the thing is that you said that these are the most common problems, but
I didn't say though, this is number one which is came to. Number two called the osteoarthritis. Osteoarthritis is number two. What does it mean, osteoarthritis? If you look, I don't know, we can put the picture. You know, between the bones there is cartilage. Okay? For this one, you move without pain. You walk without pain. Okay? What's the use of these cartilage? Cartilage is like a sponge. There's no nerve or no blood supply for this one. For this reason, you walk without pain. If something happened to this cartilage, disintegrate or any injury, so you will suffer from pain. Who are those complaining of osteoarthritis? Is those who are elderly people. If you pass the age of 50, 60, then you are liable to get osteoarthritis. So it's called age-related osteoarthritis. There's no way to get rid of it. Okay? You cannot stop your age. The other cause is called if you have repetitive inflammation in the joint. Like if you have, we'll talk about it, if you have rheumatoid or gout or anything that inflamed your joint and you don't treat it well or as early as possible, at the end it will destroy your cartilage. So they get secondary osteoarthritis. Those who get secondary osteoarthritis, the same complaint what happened with those who are above the age of 60. They get complaint of pain when they walk and when they use the joint. Number three called autoimmune disease. This is also came number three, which is also in Kuwaitis. And this is actually done only pure Kuwaitis after the age of 15-year-old, male, female, and we took it randomly all over the government of Kuwait. And autoimmune disease also common. And the commonest came is rheumatoid arthritis. I'm sure they don't know what, not everybody knows what's rheumatoid arthritis. It's an autoimmune disease, and we don't know the cause. It's something happened to immunity. At the end, it will fight your joints. And this is what it means, rheumatoid arthritis.
Now, we're going to a short break, and we will continue our talk about rheumatoid arthritis, so stay tuned.
Dr. Ihab Abdullah. I'm a public health physician. I work in the Ministry of Health. I'm specialized in health education and behavior change. I'm here today for this campaign against smoking. We are committed for this program to try to convince youth and mainly youth and old men to quit smoking. We are here for this is here for the second day now, and we meet with the different age groups, especially youth from age something like 16 years to 30 years. We try to discuss with them why do they smoke and what are the benefits for smoking. We try to open discussion with them. And then we give them our address in the no smoking clinic in Faiha to meet them again there, so we can talk more about the problem of smoking and how they can how to help them to stop smoking, how to overcome this behavior, and how to try different ways to change this behavior.
a loyal volunteer. We're here 360 for 5 days for a campaign called Be Smart, Don't Start, to prevent youth from smoking. And we've collected these cigarettes from youth and we gave them flowers instead. We have messages from children to their fathers and parents, and we have messages from parents to their children.
Ali Al-Sakawi, I'm a football freestyler. Basically, I do skills with the ball, and I'm here to do some skills to attract the audience in order for the other volunteers to talk to a large number of people at the same time. And this will be more efficient to give them advice about anti-smoking and more prone to take the advice from something that they actually enjoy watching.
Welcome back, dear viewers, and we were talking about rheumatoid arthritis with the professor, and can you just tell us again, rheumatoid arthritis is an autoimmunological disease, as you said, is it?
Yeah, it's an autoimmune disease. What does it mean, autoimmune disease? Everybody has immunity.
Yeah.
Okay, and this immunity fights the stranger.
Yeah.
Like if you have viruses went into your body or you have bacteria, then this immunity gets activated and fight the virus or the bacteria. So somehow it happens that this immunity, we don't know what happened exactly and what triggers it and what's the exact cause. It becomes what we call, it fights your body. We don't know the reason yet. We think some molecule happened to these cells which is fighting, and at the end it deranges you and fights your joints or other organs. There is many factors. They come together and play, and at the end will disturb your immunity and fight your body. We think that if you are female, you are more prone to get rheumatoid arthritis.
Yeah.
If you have more estrogen in your circulation, like female, they have more estrogen. They say they're hormonal, especially estrogen. They're prone to get autoimmune diseases. What's called inheritance. If your father or your mother has rheumatoid, you have 5 times risk to get rheumatoid arthritis, but it's not a mandatory.
Yeah.
We have family, their father have, but the kids they don't have, but they are higher risk to have.
Higher risk, yeah.
Number 4, they say it's if you have a strange virus came into your system, Epstein-Barr virus, cytomegalovirus. This is one of the theories they said. And number 5 is the stress. They said if you are under heavy stress, should be an emotional stress, you know,
Yeah.
and bombarded by a heavy emotion. At the end, you can have an autoimmune disease or
Which is
like
the thing
rheumatoid.
about autoimmune diseases. They're mostly, most of them are, you know, related to stress as
To
well.
stress, yeah.
And it's very
There are many
strange.
studies, you know. I have patients, you know, they slept and they woke up because they're under stress and they start to have rheumatoid arthritis. And even rheumatoid arthritis, it gets worse or get activated or get flare if you are under stress. And the control of the disease become very difficult. So stress itself not only can bring the disease and also can activate the disease.
Yeah, which
Okay.
is...
So these
everybody
are the
should distress and
yeah, stress.
relax.
So you have to be stressed, relax.
Absolutely.
And female more than male, we said, ratio is 4:1, and the percentage is 1 in 100.
Is this in Kuwait?
Also in Kuwait, yeah.
Oh, okay.
So it's the same as worldwide, the prevalence of rheumatoid arthritis. It's 1 in 100. So every 100, one they have rheumatoid arthritis.
Yeah. Now the thing is about rheumatoid arthritis, especially in women. I think it's a major concern.
Yeah. It's very common in childbearing age.
Okay.
The age is usually the peak is between 20 to 50.
Oh, okay.
So it happens in the age which is the woman or the man can produce, they're very productive. So they affect at this peak age when they're young.
When they're young.
They're young, yeah. Yeah.
And does this affect, for example, women who are going to get married and...
Yeah, correct, you know. Before we talk, I would just like to show this picture.
Yeah, go ahead.
This is one of my patients. This is the early rheumatoid arthritis. If you look at the hands, they're swollen, you know. The joints, usually if you look at the wrist joint, this joint, the knuckle joint, the MCP joints and PIP, and the whole finger of the hand is swollen. And this is the early manifestation or early symptom of rheumatoid. So they complain of joint pain, especially when they wake up in the morning. They have very severe pain in the morning. Number 2, they have what's called morning stiffness. They have difficulty in moving the joint. You know, when you wake up, you should move your joint right away without any problem. This patient takes about, you know, this patient, she said to me, it takes more than 3 hours to move her joint, to make a fist.
Which is almost characteristic of...
Characteristic for rheumatoid arthritis. So pain, swelling, it happens swelling in the joint or around the joint. Number 2, stiffness, also very common. And not only the hand, it can affect the knees, can affect the feet, can affect the elbows, can affect the shoulder.
Yeah.
And the patient could be crippled and cannot function like before. It could be associated in early phase of rheumatoid. They can have fever, they can have weight loss, they can have fatigue, and they lose interest. Okay? So this is the earliest manifestation of rheumatoid arthritis. So you have to tackle this patient as early as possible because times matter to us. Very
now,
important.
is there, for example, for these patients, is there any good prognosis for them?
Yeah, good prognosis if they come early to us.
Early.
Very good prognosis, and many studies have proved that the earlier presentation to you, to the doctor, the earlier diagnosis and the earlier treatment, the better prognosis.
And what do you think here in Kuwait? Do we have a good system of detecting this disease, or?
Yeah, we're doing lots of awareness and campaign, not to the public. We're doing also to the doctors, the general practitioner, to non-rheumatologists. We need these, you know, those who are suffering from rheumatoid to come to us as early as possible. And we started now a clinic called Early Arthritis Clinic in Amir Hospital. We want to catch these patients as early as possible. Before they said, you know, 2 years then you try to treat it. This is no way, this is totally changed in the last 10 years. Now we need 6 weeks to start treatment, the aggressive treatment.
Okay.
Because we know we had, if you look at this picture, you know, this picture, real patient, there has been delayed, you know. See the fingers become crooked, you know.
Yeah, yeah.
Okay? At this stage, you cannot do anything with the treatment. You cannot do anything. She will remain for her life like this one. Nobody likes, especially in young patient, to say with this, like this hand.
Exactly.
I'll show you another
because
picture.
it's very disfiguring, and especially
Disfiguring,
for
yeah. And they lose the function
yeah,
of the hand. They cannot.
that's the thing.
Yeah, they cannot. You know, if they want to cook, they cannot. They want to write, they cannot. They completely. There's another one patient. Okay, she came to me late, after 10 years of the treatment of the rheumatoid. This one cannot do anything for it. I'll show you another, which is also severe form of rheumatoid arthritis.
Severe, yeah?
This is called rheumatoid mutilans. This patient, he had rheumatoid for more than 30 years, and this I cannot do anything for her, unfortunately. We just relieve her pain, we release her, suffer, but we cannot do anything for the function, because function is very important. So we need this patient with rheumatoid arthritis to come as early as possible, and we're doing campaign all over Kuwait, to educate them and highlight all about rheumatoid arthritis, because the earlier they come to us, the better prognosis.
Absolutely agree. Now we have a question from one of our viewers, and I think a lot of people have this idea in their minds. She has rheumatoid arthritis, and she is wondering, should she use a jacuzzi to treat her rheumatoid arthritis?
She can use jacuzzi, provided she should be treated with a drug.
Yeah, so it doesn't
jacuzzi is not a treatment.
Yeah.
It helps her to strengthen her muscle. These inflamed joints, what happens to the muscle around them, become weaker. Okay, the more weaker the muscle, even they lose the function of the joint. And jacuzzi also alleviate the pain and reduce the pain. So it helps to alleviate the pain, provided she should be treated with drugs for rheumatoid arthritis under the care of rheumatologist. They should be treated. So jacuzzi by itself is not treatment. It helps.
It just helps.
It helps, yeah.
And now the thing is, this is the thing that I really want to know about is the impact of this disease on women. Because, of course, it can cause disfiguring and also problems in the functioning of the joints. And can you tell us about the problems this impacts on women? Yeah,
as I told you, if you get many joints affected, so at the end what happens, it affects your function. It causes disability. Disability means the patient cannot function like before.
Yeah.
Okay? If this patient is living only on her salary, or she's living salary, especially in the government can give you pension, retirement pension, if you have severe rheumatoid. But if in a private company, they will fire her out. They will fire her.
Big issue.
And when she's fired, means no money coming to you, especially if she's sponsoring the kid, no money for the kids. And we had many problems. Even suicide has been committed, because there's no support. Especially if divorced.
Yeah.
So treatment of rheumatoid is a team approach. So we need also a social worker, a psychiatrist to help this patient. Otherwise, they're not only disabled, it affects also in the psychosocial aspect of their life. Very tragic. We're so tragic, and we don't like this happen to our patients.
Now, the medications used in rheumatoid arthritis, of course, if a woman wants to get pregnant during this, can she take the medications and get pregnant, or should she stop the medications? Yeah,
so the good news in rheumatoid, if you get pregnant, 80% the symptoms of rheumatoid disappear. This is the good news. So if a rheumatoid patient came to me and she wanted to, I tell her, go ahead and get pregnant. 80% their swelling, the activity of rheumatoid arthritis will disappear. Why? Because they are substance produced by placenta and suppress the inflammation. 80%. Only 20% they need treatment. And usually don't give a treatment which affects the baby, what's called teratogenic, means it causes malformation. We like to use drug which has no teratogenic effect, means it doesn't cause malformation in the baby. And I try with Benadryl, the plain Benadryl, which is not teratogenic. And if it doesn't help, we add small dose steroid. And this also will relieve the pain and the inflammation. They can continue all along the pregnancy when they deliver. If they want to do breastfeeding, they can go ahead even with prednisone, no problem.
Yeah.
If not, then we can go back and restart them on the treatment, the previous treatment. The previous treatment we restart, and now the treatment of rheumatoid arthritis, we are very aggressive in the treatment. Young female, she came to me with rheumatoid, new onset rheumatoid. This all has been changed over the last 10 to 15 years. We use an aggressive treatment called, the cornerstone of the treatment is called methotrexate. Everybody's scared about methotrexate because it's a chemotherapy. It's not a chemotherapy. It's chemotherapy. We use very high dose.
Yeah.
We use only 1/10 of the dose of methotrexate, 15 to 20 milligram per week. Provided she should be observed by her rheumatologist. We could put a close eye on her every month. We repeat liver function, we affect the renal function. We do also complete blood count to check her hemoglobin, to check her white blood cells and platelet. If anything happens, they will tell her that we should reduce or increase the dose. If this didn't control her symptom or her activity of rheumatoid, then we go to a biologic therapy. This biologic therapy is a revolution over
So it's new therapy?
the new type of treatment
Okay.
over the last 10 to 15 years. And it is what called, it is a smart weapon. The same, it goes, where is the inflammation? Okay? We give it. There are many types of these biologic. Some of them are given under the skin, like you give insulin under the skin. Some of them intravenous. Now the new comer coming now, I think next year, is the oral one. So you take it by pill. This works, where is the inflammation, and goes and stop what we call the function of this molecule, because there are many molecules that cause inflammation, called cytokine, in the joint and in the blood system. And this stops it, and the patient will feel better, the inflammation goes down, and he will live normal life. And even the what we call the destruction, which I showed with this, like this patient, we have many patients that no more like this one, which I'm showing here. They're living healthy life and almost back to the normal their function.
Now the thing is there other developments in treating rheumatoid arthritis? Are there any new developments other than that, or other methods of treating this?
As I told you, there are many things coming now in the market in the interleukin phase,
Yeah.
Before we know 1 or 2 interleukins, now increased to 10, now almost 35 interleukins.
Wow.
Yeah, they're working lots now. The new drug coming now in the market, I think they're called interleukin 23, 25. They're all these coming in the market, and they all will be proved to be very effective in the treating rheumatoid arthritis. We coming now to, we put now the activity almost to what we call inactive disease, or remission we call it. Our goal now is to prevent this disease. There are many studies now coming that if we can prevent the disease, this is what we call a dream. Okay? To prevent the disease, now many studies coming that we can detect what we call antibodies in the circulation, called anti-CCP. And this has been shown that it may also cause rheumatoid arthritis. And those patients giving prevention treatment as before they develop, but their studies still not proven yet, maybe we switch off the disease. But still we need more study that we can prevent disease as if these studies show to be proven.
We have another question from one of our viewers, and it's he's concerned about does cold weather or being in a cold atmosphere gives you rheumatoid arthritis?
Yeah, see, cold weather doesn't cause rheumatoid arthritis.
Yeah.
Because it's autoimmune disease and we don't know why it happens. But we know that cold weather increases the pain of rheumatoid. Okay, so most of the people with rheumatoid, they don't like exposure to
Even
cold.
in normal people.
Even normal people, they don't like. So they don't like cold exposure.
Yeah, yeah.
So cold weather doesn't cause rheumatoid arthritis, but if you have rheumatoid arthritis, the pain gets worse. So most of the people, when they wake up, they don't like, cold water on their body, when they take a shower. They like a warm water. because shown to be warm water can ease out the pain, and the joints get more lax and they can move easily. But the cold weather becomes worse, so they don't like a cold weather. But it doesn't cause the disease. We don't know the cause of the disease of rheumatoid arthritis yet.
Now, Professor, we've reached the end of our show, but do you have any message or advice you want to give to the audience?
Yeah, my advice number one is there's rheumatic disease. There's certain rheumatism you can prevent it, what's called the soft tissue rheumatism. Okay, that the healthy way of sitting, lifting, sleeping can prevent you from rheumatic. But there's some rheumatic disease you cannot do it, like an autoimmune disease.
Yeah.
Healthy, what we call a healthy food, okay, also important. We didn't talk about the bones, okay? You need calcium, you need vitamin D, you need vitamins because they're called radicals. They're very important. These radicals can destroy your joints. So if you eat healthy food, can prevent you also disease. Exercise, also very important. Exercise, it strengthens your muscle, strengthens your bone, strengthens your joint. So
I think it's the biggest issue that they don't exercise. I think it's very important.
Yeah, we don't like obesity in rheumatoid arthritis. Obesity also can cause problem, like osteoarthritis. We see many patients with obese, male or female, can cause joint destruction, especially the knee osteoarthritis. We have many examples, so we don't like.
Absolutely.
And also what we call, they should listen to their doctors.
Yeah.
We don't like in rheumatology doctor shopping, okay? You know, understand what I mean, doctor shopping. You know, rheumatoid, it's a chronic disease, okay? There's no cure so far. And they go from doctor to doctor, and each doctor changes the
Which is a huge, I think it's a huge problem as well.
Huge problem. So, okay, one or two opinion, I don't mind, but not more than like that. They should stick to the advice and the treatment of their treating doctor. And number 5 is they should avoid stress. Everybody should be happy. And it can, as I showed you, the study showed that, they're less prone to get autoimmune disease.
Thank you so much, doctor, for being here. And thank you so much as well, viewers, for watching us. And watch us next week with a new episode. And have a good night.